Good afternoon, and thank you for joining us today. Our presentation today is entitled Ebola Preparedness, Mission Critical for Hospitals and Health Systems. My name is Heather Fields, and I'm a member of Reinhardt's Healthcare Department, and I chair our Hospital and Health System Practice Group. We've assembled a great team for you here today to talk about some of the less covered issues related to Ebola preparedness. And I have with me my partners Jeff Clark and Katie Triska. Jeff Clark is a shareholder in our firm's litigation, labor and employment, real estate, and environmental law practices. He's a busy guy. He actually also, really important for this particular presentation, is our go-to person for emergency preparedness and crisis management, and is one of the foremost experts on OSHA compliance, certainly in the region and probably nationwide. Katie Triska is a shareholder in our firm's labor and employment practice, and she routinely advises our healthcare clients on a variety of employment issues, not the least of which include compliance with the American with Disabilities Act, the Family and Medical Leave Act, and issues related to the National Labor Relations Act. Our presentation today is going to really focus on some of the practical and strategic points that leaders of healthcare systems, and particularly hospitals, need to be focusing on. Obviously, clinical preparation is critical. However, it's also crucial that hospital leaders approach Ebola preparedness from an enterprise risk management position and ensure that the various preparation efforts are well coordinated as well as comprehensive. It's not just the boots on the ground infection control and clinical teams that need to be involved in Ebola preparedness, but also your board of directors, all the way down to your registration staff, your security personnel, obviously sanitation staff, people who handle your supply chain need to be tapped in. Obviously, labor and human resources teams need to be very involved, and Ebola has presented an unprecedented, I think, opportunity and challenge for hospitals to coordinate with the communities that they serve in terms of their readiness to address any Ebola infections that may arise. We're going to cover the role of the board in Ebola preparedness, some of the EMTALA implications of managing Ebola, and then I'm going to turn it over to Jeff to talk about healthcare worker protection and the interplay between CDC guidelines and OSHA, as well as the risks presented to organizations in terms of OSHA compliance. We'll then turn it over to Katie to talk about some really critical labor considerations for your employees, and then I will wrap it up with some thoughts on HIPAA compliance strategies that should be considered, and we will open it up for some questions. Obviously, Ebola preparation is first and foremost an exercise in patient care and public health. However, I think the lesson learned from the Texas experience is that the inability of an organization to be prepared for a disaster of this magnitude, or at least an issue of this magnitude, can ultimately be devastating to the financial viability of an organization and really challenge its ability to meet its mission in the future. On Friday, Moody's Investors Services revised its outlook on Texas Health Resources, which is the owner of Texas Presbyterian Hospital. It has a lot of outstanding debt, and it downgraded it from positive to developing. Since the admission of the first Ebola patient in the United States to Texas Presbyterian, they've experienced a 25% drop in their revenue, and in certain regulatory documents released last Wednesday to bondholders, they disclosed that their net revenue is down 26%, down $8.1 million, and that their overall daily occupancy rates fell by nearly 80%, 78.7% to be exact. I think that just reading in the newspaper the anecdotal stories of folks who live in the Dallas area, you hear all kinds of stories about patients avoiding getting treated at Texas Presbyterian. Obviously, when interviewed on national television, one of the healthcare workers from that facility expressed some very serious concerns that she had. Whether or not those are justified, we're not going to be focusing on today, but I think it's fair to say that while hopefully Ebola will be limited in its impact over the coming months and will be successful in containing it, it really has changed the conversation around healthcare systems in a way that is particularly pertinent to top leadership of organizations. I think that there are two main fallouts from this that we are going to be dealing with in the months to come. One that we're really going to focus on today deals with the protection of your healthcare workers. It's now a topic of conversation at dinner tables. And I think previously where your average folks would not be talking about CDC standards, it's become a household reference. So labor relations are really going to be key in the coming months, I think, for successful organizations to focus on. Obviously, emergency preparedness is now something that I think folks are going to be really focusing a critical eye on, and I think that this is really unfortunate coming up on the flu season. Last but not least, I think infection control is going to have a new focus in healthcare. It was there before, but now is front and center, and I think communities are looking to know and understand from their organizations, their hospitals, what is being done to make sure that workers and patients both are protected ultimately for the good of the community. In terms of the board, I think that we will cover these slides at fairly high level for you, but I think it's critical to remember that the governing body plays a statutory role in ensuring that the hospital as an institution provides a safe environment for patients and healthcare workers. And we've cited to you the conditions of participation. Obviously, I've not heard of any efforts on the part of state agencies to conduct surveys related to Ebola preparedness, but I think in the coming months, certainly a focus will be on infection control procedures and the programs that are put in place to control the spread of infections and communicable diseases. The Joint Commission standards reflect the conditions of participation and hold the governing board ultimately accountable for the safety and quality of care, treatment, and services performed at the hospital. I think that this is a really unique opportunity for boards to really take ownership of how their organization is responding to the situation from the perspective of this legal duty that they have to oversee the activities of the hospital. And I think it's critical as part of this that there be a evaluation of the allocation of resources that are going to be needed to appropriately protect healthcare workers and patients. We have folks from a variety of states within the region on the phone, but in terms of state licensing requirements, these also reflect the role of the board that I previously mentioned under the conditions of participation and Joint Commission. And I think that it remains to be seen, again, whether or not people are going to face focused surveys on their infection control procedures and their current level of compliance with OSHA standards. In terms of the board's oversight role, I think that one of the things that I've not seen a lot of clients doing that would be worth considering is to ensure that the key elements of the organization's plan, response plan, have been explained to the board and that they understand and have had an opportunity to critically vet what the organization is doing. And I think that this is really a daunting task, anyone who is familiar with the way in which hospitals operate, because if you look at the flow of patients, it isn't solely to the emergency departments. Obviously, the large systems have many urgent care centers. They have ambulatory care sites, and so it is a very monumental task to chart the flow of patients and ensure that the organization has put in place mechanisms to manage the flow of patients who might be affected by Ebola. In terms of protecting employees, it's really important for the board to really understand what the organization is doing, not just to implement CDC guidelines, but also considering whether or not the organization has gone above and beyond and stress tested the procedures that they're putting in place. I think also understanding on a wider scale what the organization's labor relations strategy is and how it's being communicated, as well as considering whether or not there are special hotlines available for workers or patients to report special concerns. In terms of EMTALA compliance, I think really the message of Texas, again, to harken back to that example, is that not every community facility is going to be prepared and ready to treat Ebola patients. Obviously, much is going into the way of preparation efforts at facilities across the nation, but I think consideration needs to be given at a high level of leadership what the strategy is going to be, whether or not there's going to be a focus on transferring patients for treatment to regional centers that have the capability to address this very virulent virus, or if you really are going to try to do it at home. Whether or not you do that, you need to make sure that when patients come into the hospital that you are appropriately screening and stabilizing them within your capabilities. And I think that it's critical that you look at the CDC guidance in terms of implementing your procedures for conducting that initial medical examination. Patients have to be isolated in rooms with private bathrooms. That can present a lot of challenges depending on older facilities may or may not have that readily available. It's critical that there be a way to intersect with the local health department immediately if there is a patient who presents with Ebola symptoms or is reasonably expected to have had exposure. And I think it's critical that from a board level down, there's really a critical evaluation of the adequacy of the physical facilities and training and staff expertise and capabilities to treat these people. But having said that, regardless of the ongoing treatment of patients, you do need to be able to receive patients who present in your emergency department. If you're going to go the transfer route, it's critical that you understand that the transferring facility has a number of obligations under EMTALA to ensure the safety of the patient who is being transferred. And a key piece of this is that you transport the patient through a qualified transportation process, equipment, and the transferring ambulance and or whether they're going to be medevaced out. It's really critical that you think about this before the patient arrives at your hospital, obviously. And I think it's interesting, I think the CDC has yet to release their guidelines for EMS, but I know certainly in Milwaukee County, our EMS system has been very actively engaged in this, so it's critical that leadership is ensuring that there's that level of coordination with the local EMS as to how transport would occur. In terms of receiving transfers, important to remember that a hospital with specialized capabilities or facilities cannot refuse to accept a transfer from a referring hospital where that other hospital does not have those capabilities or the capacity to treat the individual. Obviously, lateral transfers between hospitals of similar resources and capabilities aren't required, but I think this presents an interesting challenge to large tertiary care facilities. I'm going to turn it over now to Jeff Clark to walk through some of the really critical OSHA issues that are raised by the recent Ebola outbreak.
Thank you, Heather. The Occupational Safety and Health Administration of the U.S. Department of Labor, popularly known as OSHA, administers the Occupational Safety and Health Act of 1970. OSHA maintains a website at www.osha.gov. OSHA's website addresses how healthcare and other employers should protect their workers from potentially being infected with Ebola. According to OSHA, EHF is the disease caused by infection with an Ebola virus. Workers performing tasks where they're in close contact with individuals who have symptoms of Ebola or in an environment that's contaminated with infectious body fluids are at risk of exposure. OSHA is also concerned about possible airborne transmission of Ebola in the workplace. This is important to keep in mind when considering how OSHA's respiratory protection regulations apply to the potential hazard posed by Ebola on the job. Though transmission through inhalation of the airborne virus is not currently a primary concern, it may be possible for the virus to be aerosolized under certain conditions. Therefore, OSHA says that employers should avoid using compressed air or water when cleaning surfaces. This might cause droplets containing infected material to become airborne or create a bioaerosol. The Occupational Safety and Health Act contains a catch-all statutory provision known as the General Duty Clause. Section 5 of the OSHA Act of 1970 requires each employer to furnish to each of its employees employment and a place of employment, and this is critical, which are free from recognized hazards that are causing or are likely to cause death or serious physical harm to the employees. Each employer must also comply with the standards promulgated by OSHA. The Act also provides that each employee, reciprocally, shall comply with OSHA standards and all rules, regulations, and orders issued by OSHA which apply to his or her own actions and conducts. OSHA has promulgated several regulatory standards which potentially apply to Ebola. These regulations include OSHA's bloodborne pathogens, personal protective equipment, or PPE, and regulatory protection standards. OSHA's bloodborne pathogen standard covers exposure to the Ebola virus. Ebola is among the subset of contact transmissible diseases to which the bloodborne standard of OSHA applies because Ebola is transmitted by blood or other potentially infectious materials as defined by OSHA in the standard. In situations where workers may be exposed to bioaerosols containing the Ebola virus, such as when chemicals are used in cleaning working surfaces, employers must also follow OSHA's respiratory protection standard. Other elements of infection control for Ebola, including precautions for contact transmissible diseases, are covered under OSHA's personal protective equipment or PPE standard. OSHA's personal protective PPE standard requires an employer to assess its workplace for hazards. Clearly, the national recognition of the dangers posed on the job by Ebola would be such a hazard that the employer should assess its workplace for. This OSHA regulation further provides that protective equipment, including that will protect the eyes, face, head, and extremities, protective clothing, respiratory devices, protective shields and barriers, shall be provided, used, and maintained in a sanitary and reliable condition whenever that would be necessitated by hazards of processes or environment. Clearly, an Ebola-infected work environment would qualify for that. Or chemical hazards, such as hazards created by chemicals used to clean a workplace of Ebola-infected material. The required PPE should include eye and face protection and respiratory protection. OSHA views the Centers for Disease Control, or CDC, as, quote, the authoritative source for information for healthcare workers who care for, treat, and otherwise interact with patients who are known to or suspected of having EHF. OSHA, therefore, will likely consider the CDC guidelines as authoritatively demonstrating that potential Ebola exposure is a recognized on-the-job hazard that can kill or seriously injure workers. Certainly the Dallas experience bears that out. OSHA's website even links to the CDC's guidance and recommendations. CDC recommends that facilities use a powered air purifying respirator, or PAPR, or an N95 or higher respirator in the event of an unexpected aerosol generating procedure. OSHA also looks for guidance to the National Institute of Occupational Safety and Health, or NIOSH. If a NIOSH certified PAPR or a NIOSH certified fit-tested N95 respirator is used by a facility, that employer must comply with all elements of the OSHA respiratory protection standard, and that includes fit testing, medical evaluation, and training of the healthcare worker. This OSHA regulation includes several mandatory appendices: fit testing, user seal check procedures, respiratory cleaning, the medical evaluation questionnaire for employees to complete, and very importantly, the OSHA Appendix D information for employees who use a respirator, whether it's required by the standard or not. Now, OSHA's PPE standard looks to the CDC recommendations that a healthcare worker in close contact with EHF patients must wear a face protection, a face shield, or a medical mask and goggles, a clean, non-sterile long-sleeve gown, and gloves. Now, the OSHA bloodborne pathogen standard is particularly applicable. It applies to all occupational exposure to blood or other potentially infectious materials. Obviously, this would include the Ebola situation. The standard requires employers to establish an exposure control plan, updated annually, use universal precautions, which the CDC guidelines would likely qualify as, use engineering controls, use appropriate work practice controls, provide PPE such as gloves, gowns, eye protection, and masks to the employees, make available the hepatitis B vaccination to all workers with potential occupational exposure, and after an exposure incident, provide post-exposure medical evaluation and medical follow-up to any occupationally exposed worker. These have to be used to communicate the hazards to the employees, that workers must be informed and trained, and the employer must maintain worker medical and training records. OSHA's hazard communication standard, as we mentioned before, may also apply to Ebola exposure situations. Employers should keep it in mind when they look at the need to protect their workers from being injured when they use chemicals to clean working surfaces or to disinfect equipment that might have been contaminated with the Ebola virus. This OSHA regulation requires employers to have comprehensive chemical hazard communication programs, including container labeling, forms of warning, safety data sheets, formerly known as MSDSs, now shortened to safety data sheet, and employee training. OSHA is also developing a proposed infectious disease standard. OSHA recognizes that employees in the healthcare and other high-risk environments face long-standing infectious disease hazards such as tuberculosis and influenza. Although OSHA believes the bloodborne pathogen standard has effectively protected workers, OSHA realizes that the standard does not address infectious diseases transmitted by other routes, such as contact, droplet, and airborne. In addition, OSHA believes that such a new standard is needed because transmission-based infection control guidelines, such as the CDC recommendations, although readily available to industry, are not consistently followed by employers, at least in the view of OSHA. OSHA has issued interim guidance for Ebola-exposed workers. Employers should follow recognized and generally accepted good infection control practices and meet the requirements in the PPE standard and the respiratory protection standard. In particular, OSHA will look to the infection control practices as recommended by the Centers for Disease Control and Prevention, or CDC. On Monday, October 20th, CDC released tightened guidance for U.S. healthcare workers on the PPE they should use for Ebola. This guidance has three main principles. Employers must rigorously train all healthcare workers regarding PPE, including how to correctly put it on and take it off. Obviously, the Dallas experience shows the need for that. Also, the Dallas experience shows the second point being valid. There can be no skin exposure when PPE is worn. And finally, to make sure this is done, a trained monitor should supervise all workers who wear PPE and watch each worker putting on and taking off his or her PPE. Principle number one of the CDC guidelines is rigorous and repeated training. The CDC and OSHA are concerned that relying solely on PPE can give a false sense of security. Therefore, effective training is critical. The second principle, no exposure of the skin when PPE is worn. Therefore, the worker should wear double gloves. They should have boot covers that are waterproof and at least cover the mid-calf. There should be a resistant or impermeable gown that again extends to at least mid-calf. Respirators, including either an N95 or a PAPR, should be used. A full face shield should be worn. A surgical hood that completely covers the head and neck should be utilized. And finally, an apron that is waterproof and covers the torso to the mid-calf should be used if the Ebola patient might be vomiting or having diarrhea. The third principle is the trained monitor. We want to make sure there's a trained monitor actively and observing in supervising each worker putting on and taking off the PPE. OSHA recognizes the existence of both worker and employer rights in the Ebola situation. In OSHA's view, any worker who may reasonably be expected to come into contact with the Ebola virus, either from the work environment or directly contacting an individual infected with Ebola, has the right to know the hazards associated with this potential exposure and how to protect themselves during the work activity. OSHA's hazard communication standard does not apply to the Ebola virus itself, but employers are required to comply with the standard when chemicals are used to clean and disinfect the work environment. OSHA provides whistleblower protection to employees. The OSHA Act provides that no person shall discharge or discriminate against an employee because the employee files a complaint or participates in a proceeding or testifies in a proceeding or exercises rights on behalf of himself, herself, or others of any rights afforded by the OSHA Act. The Act further states that an employee who believes that he or she has been discharged or otherwise discriminated against by any person in violation of 11C of the OSHA Act may, within 30 days after such violation occurs, file a complaint with OSHA alleging such discrimination. OSHA has also entered into a work-sharing agreement with the National Labor Relations Board, which Katie will touch upon in a moment, and under that particular work-sharing understanding, if an employee may have exceeded the 30-day notice requirement of OSHA so that OSHA wouldn't have jurisdiction to investigate the complaint, OSHA will cross-refer that to the NLRB to investigate because then the NLRB has up to 6 months to conduct such an investigation. What happens if an employee in a hospital receives appropriate PPE and training from the employer, but nonetheless unreasonably refuses to treat an Ebola patient? By a promulgated regulation, OSHA recognizes that generally there is no right afforded by the Act entitling employees to walk off the job because of potentially unsafe workplace conditions. OSHA is aware, however, that hazardous conditions which might violate the Act will ordinarily be corrected to the employer once the employee brings the hazard to the attention of the employer. According to OSHA, if these corrections are not accomplished, or if the employee disputes with the employer the existence of a hazard, the employee can then have the opportunity to ask OSHA to inspect the workplace under Section 8F of the Act. Under such circumstances, therefore, OSHA recognizes that an employer would not ordinarily violate Section 11C by taking action to discipline an employee who refuses to perform his or her normal job activities because of alleged safety or health hazards. OSHA also recognizes, however, that occasions could arise when an employee must decide between not performing an assigned task or subjecting himself or herself to what they fear would be serious injury or death from a hazardous condition at the workplace. OSHA says that the controlling test is one of reasonableness. If the employee with no reasonable alternative refuses in good faith to expose himself or herself to the dangerous condition, he or she would be protected against subsequent discrimination. According to this OSHA regulation, the condition causing the employee to apprehend death or injury has to be of a nature that a reasonable person, under the circumstances confronting the employee, would conclude there is a real danger of death or serious injury and that there's insufficient time, due to the situation being urgent, to eliminate the danger through resort to regular channels. In addition, OSHA requires that the employee, whenever possible, must also seek from the employer and have been unable to obtain from the employer a correction of the dangerous condition. OSHA also recognizes the right of an employer to enforce its reasonable safety rules. As a result, OSHA has promulgated a regulation providing that employees who refuse to comply with occupational safety and health standards or valid safety rules implemented by the employer pursuant to the OSHA Act are not exercising rights afforded by the Act. According to OSHA, disciplinary measures taken by employers solely in response to an employee refusal to comply with appropriate safety rules and regulations will not ordinarily be regarded by OSHA as discriminatory action prohibited by Section 11C of the Act. This situation should be distinguished from refusals to work, which we discussed previously. In summary, the correct application of these OSHA regulations in the Ebola context in a given workplace environment depends on the particular facts and circumstances of the specific situation. OSHA will evaluate the reasonableness of the conduct of both the employer and the worker in a given situation involving potential worker exposure to Ebola on the job. Katie Triska will now address ADA, FMLA, NLRA, and other labor and employment law considerations relevant to Ebola preparedness.
Thank you, Jeff. Good afternoon. It's clear in reading the news that employers are struggling with how to handle concerns about Ebola in the workplace. Not only are employers worried about protecting their employees and patients, but they are also under intense scrutiny by the media and community. For example, a North Carolina principal was required to stay at home for 21 days after returning from a mission trip to South Africa, despite the fact South Africa is 3,000 miles away from regions with an outbreak. A teacher in Maine was placed on a 21-day leave of absence after parents expressed concern about her merely attending a conference in Dallas. Employers need to plan now for how to address an outbreak so that they are able to respond in a manner that protects the workforce and patients and minimizes exposure under employment laws. As you'll hear today, many of these laws require employers to consider issues that arise relating to Ebola on a case-by-case basis. There is no one-size-fits-all. Therefore, the goal today is to provide you with an overview of the laws and principles that will apply when confronting an Ebola outbreak. So to begin, the first law we're going to discuss is the Americans with Disabilities Act. A disability is defined as a physical or mental impairment that substantially limits one or more major life activities. Disability is very broadly defined. It likely includes such conditions as arthritis, diabetes, and depression. Under the ADA, an employer is required to provide a reasonable accommodation to a qualified individual with a disability who is an applicant or employee, unless to do so would cause an undue hardship. Accommodations can include making existing facilities available, job restructuring, modifying equipment, modifying work schedules, etc. The employee doesn't need to specifically request a quote-unquote reasonable accommodation or even mention the ADA. Instead, it's enough that the employers put on notice that due to medical issues, an employee needs some assistance. The ADA limits when an employer can require individuals to undergo a medical exam. A medical exam is also defined rather broadly to include any procedure or test that seeks information about an individual's impairment or health. Medical exams are prohibited of all applicants before a conditional offer of employment is made. However, once a conditional offer of employment is made, then employers may require medical exams, but only if that's required of all entering employees in the same job category. We're going to focus now on when we can require medical exams of current employees. Under the ADA, we can only do so if it's job-related and consistent with business necessity. What this means is that an employer has a reasonable belief based on objective evidence that an employee's ability to perform essential job functions will be impaired by a medical condition, or an employee will pose a direct threat due to a medical condition. We're going to focus on this last point, the direct threat. A direct threat is defined as a significant risk of substantial harm to the health or safety of the individual or others that cannot be eliminated or reduced by reasonable accommodation. We need to consider the duration of the risk, nature and severity of the potential harm, likelihood that potential harm would occur, and the imminence of the potential harm. In the Ebola context, we'd want to rely on the latest CDC and state or local public health assessments in considering these above 4 factors. Note the reason, too, that we're really interested in knowing whether someone poses a direct threat is if they pose a direct threat, even with an accommodation, then they're not protected by the ADA's non-discrimination provisions, and our hands aren't tied so much as far as what we can do with these individuals. Another question that's relevant here is when can an employer ask medical questions? The ADA restricts an employer's ability to make disability-related inquiries. An inquiry is disability-related if it's likely to elicit information about a disability. For example, if you ask someone if their immune system's compromised, that would be considered a disability-related inquiry. But if you're just asking them instead about symptoms of a cold, that wouldn't be considered a disability-related inquiry because it's not likely to elicit information about a disability. So with this background, let's look then at what the ADA implications are of Ebola. First, is Ebola a disability? It's uncertain. It's possible that it may be, given how severe it is, despite the fact that it's temporary in nature. I think to be conservative, employers should proceed as though it is a disability and worry about their obligations under the ADA. If an applicant or employee has Ebola, then employers need to consider what possible accommodations may be appropriate. Based on what we've heard so far in the news, accommodations may include the individual working from home or being granted a leave of absence while they're recovering from Ebola. Even after they've recovered from Ebola, they may be entitled to an accommodation if they have certain restrictions or limitations upon their return. Another question employers often have is, how much information can I ask about employees when they report feeling ill at work or call in sick? Again, going back to the disability-related inquiry, you can ask employees if they're experiencing certain symptoms such as fever, headache, nausea. You can also require self-reporting. If you're able to establish that a direct threat exists or that the employee's ability to perform essential job functions is impaired by a medical condition, then in those situations that we just discussed, you'd be able to also ask those disability-related inquiries. Some employers have expressed an interest in requiring all employees to submit to regular temperature checks. This should be done very cautiously because a temperature check is considered a medical exam, so we would have to comply with the ADA's limitations on medical exams. So for example, if we'd be able to establish that there was a direct threat, for example, an employee had been an aid worker caring for Ebola patients in West Africa, then we might be able to proceed with a regular temperature check. However, in contrast, if the employee was just a business traveler in West Africa with no contact with Ebola patients, it'd be more difficult to establish a direct threat that would justify the temperature check. Some employers have already expressed that if an employee is displaying Ebola symptoms, they want to send the employees home. Generally, it's not a problem for an employer to have a policy that says if you have a temperature, if you're sick, you shouldn't be reporting to work. In addition, if we'd be able to establish that the employee's presence was a direct threat, we could also require them to go home. Now, to reduce potential damages in the event of litigation and to help minimize morale issues or bad PR, employers should consider whether they'd want to pay employees for any mandatory absence. Last here, if an employer is interested in having an employee report travel to locations where there's been an Ebola outbreak or contact with an Ebola-infected individual, that's fine. That's not considered a disability-related inquiry. However, if they should disclose any information regarding medical issues they're experiencing, then to just make sure that you're maintaining that in a separate confidential file. Lastly, while we're focusing here on the Americans with Disabilities Act, which is a federal law, I'd also suggest that employers ensure compliance with the applicable state disability law that applies to. Just real briefly with Title VII, whenever employers are devising their Ebola response, it's important that they're not doing so in a way that discriminates based on race or national origin. So for example, questions regarding potential exposure should not be limited only to employees who are of West African descent. Next, we're going to focus on the Family and Medical Leave Act. Under this act, employees are eligible for 12 weeks of leave in certain situations. For example, if they have a serious health condition or their family has a serious health condition, some military-related reasons, pregnancy, following the birth of a child. Some states also have family and medical leave laws. Ebola is almost certainly going to constitute a serious health condition, even though it affects employees differently. It's hard to think of a situation in which it wouldn't be a serious health condition. So in light of that, employers should be prepared to offer FMLA leave to employees who have Ebola or employees who need to care for family members with Ebola. Note, even if an employee doesn't specifically request FMLA leave, the employer will still need to offer an employee FMLA paperwork once it has reason to know the employee's absence may be for an FMLA qualifying reason. In addition, if an employee exhausts their 12 weeks of FMLA leave because they have Ebola, then the employer needs to consider whether it may be obligated to extend their leave due to requirements under other laws, such as the ADA, which might say that's a reasonable accommodation to grant them additional time off to recover from Ebola. It's also important to note that it's not necessary that the employee actually be diagnosed with Ebola. If instead an employee is undergoing observation because it's suspected that they might have Ebola, that could constitute a serious health condition. So bear that in mind too as you're processing these requests. As you know, under the Federal Family and Medical Leave Act, that leave's unpaid, but employers can require employees to use their PTO while on FMLA leave. So review your policies to make sure that you're complying with them. In addition, review your STD, short-term disability policy, to confirm whether an employee who's absent due to Ebola might qualify for benefits. The last law we're going to discuss this afternoon is the National Labor Relations Act. Under this law, non-supervisory employees, even non-union employees, have the right to engage in concerted activity for their mutual aid and protection. So what this means is that comments that are made on social media or to the press may be protected activity, in which case the employer can't retaliate against the employee for engaging in that activity. Similarly, if an employee refuses to work, such as deciding to strike, then that activity may also be protected. It's important for employers to determine whether employees have engaged in protected activity prior to issuing any discipline. The other comment I'd make here is that we're seeing that nurses' unions have already begun using the Ebola outbreak in Texas as an opportunity to make headway with organizing, and so to be mindful of that with your workforce as well. So in light of these laws, a few recommendations on how to proceed from here. One, it's important for organizations to be diligent and prepared for an outbreak, but not overactive. In the example I described earlier, banning an employee who traveled to South Africa from reporting to work just doesn't make sense. Second, the employer should review their leave and time off policies. For example, what are the procedures and protocols when an employee returns to the U.S. from an area in which there was an outbreak? Will quarantine be required? If so, in what circumstances? And for how long? How will you verify compliance with the quarantine? When will you require the medical exam? And who is going to make that determination that a medical exam is appropriate? Will you allow employees to work from home if they have concerns about contracting Ebola or if they themselves may have been exposed? Who will be the medical expert that you'll consult with who has infectious disease expertise that can address the questions you may have? Do you have the name and contact information for the public health official who will be responsible for your region? Do you have an 800 number that exists for employees to report if there's any situation that might present a danger? How will you notify employees if an outbreak occurs? And how will operations continue during an outbreak? Who are the members of the emergency response team? What are the self-reporting requirements of potential symptoms for employees or visitors? I'd also suggest that you review hygiene practices and what those requirements are, and whether you would want to grant any exceptions to your existing policies, such as a maximum on sick days in the event there's a CDC identified outbreak. Finally, it's important that employees are trained and educated on how Ebola is spread, the signs and symptoms of the virus, and what the company's safety policies and expectations are, and that the organization maintain great communication with its employees and patients, explaining the steps it's taking to prevent exposure and to protect its employees and patients. As I mentioned earlier, any medical information that's collected by the employer needs to be kept confidential and not in personnel files. And then finally, you may find EEOC's guidance on pandemic preparedness helpful. That's available online, or alternatively, feel free to email Reinhardt and we can provide you with a copy of that document as well. Heather Fields will now discuss HIPAA issues applicable to Ebola. Thanks, Katie. That was really helpful. So we're going to just cover lightly some HIPAA considerations in terms of Ebola. I think first and foremost, obviously, HIPAA is not going to prohibit a covered entity from making required reports related to suspected Ebola cases. It explicitly permits these types of disclosures to public health authorities who are legally authorized to receive the reports. And I think obviously you need to be thinking about not only CDC type reports, but also to your local health department and state agencies. And so wanted to make sure people understand very clearly HIPAA is not going to stand in the way of your public health reporting. What you do need to remember with any kind of report is that you have to abide by the minimum necessary rule, which means that you cannot report more than is necessary to fulfill your reporting obligation. Obviously, in terms of disclosing to others who are at risk of contracting a disease, this really needs to be handled through the public health authorities to make sure that interventions and investigations to identify persons who may have had contact with suspected Ebola patients or patients who have been diagnosed with Ebola, you need to be really mindful of this. What HIPAA does prohibit would be employee statements to the press outside the context of required public health reporting and coordination. So it's critical that organizations consider whether or not they develop, if they don't already have one, what I'm going to call, for lack of a better term, a VIP policy and procedure, something that you can implement quickly if you need it. It might include email blasts to remind employees about the hospital's HIPAA policies and procedures and the consequences of inappropriately accessing medical records or sharing information. Record locks on the medical records of Ebola patients or persons who are suspected of maybe having exposure to the disease. It would be a good idea to do access audits if you did have an Ebola patient being treated at your hospital. And certainly one option that you frequently see where you have patients who do have something that is of public interest, an Ebola infection, you might want to register them under an alias. Very difficult to implement this on an ad hoc basis at the last minute, so it is worth considering, if you don't already have something like this, that you would have it ready to go and deploy in a time of need. In addition to providing some of these additional resources, I wanted to just do a quick recap of the key steps that we think organizations should be thinking about in terms of Ebola preparedness. And certainly this would apply to your preparedness to handle any kind of wide-scale pandemic and or natural disaster. I think that critical that you engage your board. One thing that in our limited time we didn't have an opportunity to discuss is just the huge financial impact of all of this preparation, which hopefully and scientifically should not be something that most hospitals have to deal with. Huge, huge financial outlays are going to require that the board be notified, but I think that as we've cited, your basic requirements for participating in the Medicare program and Joint Commission require that your board be engaged in your quality and safety efforts all along. Really, really important, secondly, that you coordinate the various preparation activities at the enterprise level. Maybe you need to have an Ebola czar for your organization. I know that that term has received a lot of negative press as of late, but I think it's critical at a time like this that there be an individual who has both the real and the apparent authority to coordinate and govern the various silos of activity that are taking place and ensure that there really is a coordinated response. Third, I would say that it's really important to have a proactive and organized communications plan. And this plan is not only focused on members of your workforce and patients of your facility, but also the community at large that will effectively and at least efficiently provide updates and information for people as situations change as to what they should be doing, what is being done to protect them, and what's on the horizon. I think that one of the lessons of Texas is that it's really critical that you have simple channels of communication. So when employees have concerns about their PPE, there is a high-level phone number they can reach and get right to the top of the issue and make sure that there's an immediate response to their concerns. A lot can be said for the ability of someone at a high level who has the authority to, and power to deal with something, getting you know, the news that there is an issue as soon as possible. And that is a daunting task in the complex environment in which people work in hospitals. I'd say last but not least, it's really, really important that you have drills and you're constantly testing your containment procedures. There are evolving standards and approaches that are varying regionally. We've seen this play out in New Jersey where you have state health authorities that are taking a different position than the CDC, then are taking a different position of perhaps a local public health department. So I think it's critical to know and understand any differences between CDC guidance and your local and state health departments, and make sure you're working with authorities, your legal counsel, and others who are involved in your Ebola coordination efforts to really try to ascertain what your approach is going to be. With that, I am going to open it up for questions. We do have several questions that were submitted electronically. I'm going to start with one related to EMTALA. The question is, does the law specify where a medical screening exam has to take place? For example, if a hospital expects an incoming Ebola patient via ambulance and has a designated Ebola unit that is not in the ER, can that patient go directly to that unit? And the answer is yes, absolutely. There's no requirement that the medical screening actually take place physically in the emergency department, and wholly appropriate in this case that you would have a special unit where the patient would be appropriately isolated and folks who are performing that screening are appropriately protected. I would also add that the Ebola obligations end once a patient is admitted as an inpatient, generally speaking. There are some exceptions to that, but generally speaking, once the patient has been admitted to your hospital as an inpatient, they're going to be receiving active treatment, and you're going to be able to, generally speaking, extinguish your EMTALA obligations. We also have a question related to FMLA that Katie is going to answer. I believe the question related to whether or not FMLA is going to apply and whether Ebola will constitute a triggering condition.
Yes. You'd have to, of course, look at the certification form to confirm that the condition qualifies as a serious health condition. But based on my understanding of Ebola and how it affects individuals, I'd be very surprised if it didn't constitute a serious health condition. Assuming it constituted a serious health condition, then yes, you could designate it as FMLA leave. The second part of that question is, what if the individual is quarantined? If they're quarantined because we're trying to determine whether they have Ebola and we're doing the tests necessary, then that period of time in which they're in isolation, we're running tests to determine whether they have it, likely that would also constitute a serious health condition and the individual would qualify for FMLA leave, because the definition of serious health condition includes treatment to determine if a condition exists. Jeff, I believe we have some questions related to PPE.
Yes. Question, what are the PPE recommendations for ambulatory settings? On Monday, October 20th, the CDC issued its enhanced Ebola guidance for PPE for healthcare workers. This presumably would include an ambulatory healthcare setting. No worker skin exposure when the PPE is worn. And so I would invite that the questioner look at the CDC guidance principle number 2, which I believe appears on our PowerPoint slide number 28. Arguably, you would think that would apply to the ambulatory setting as well as hospitals, provided that you have employees exposed to Ebola patients or patients symptomatic with Ebola. In terms of the particular PPE, the double gloves, the boot covers, the resistant gown, the respirators, the face shield, the surgical hood that covers the head and neck, the apron that's waterproof and can be used to go down to the mid-calf if the Ebola patient is vomiting or have diarrhea. And very importantly, the CDC is emphasizing no skin exposure on the healthcare worker when PPE is worn. We also have a question concerning OSHA, the employee refusal to work in a situation. Clarify the statement regarding an employee's right to refuse to work in an area with a potential Ebola patient. If training, competency, and equipment are provided, can the employee still refuse to provide care and be protected under OSHA? Again, in this situation, OSHA would reasonably balance two competing considerations. Number one, if the employee with no reasonable alternative refuses in good faith to expose himself or herself to a dangerous condition, then he or she would be protected against subsequent discrimination by the employer. However, according to OSHA, the condition causing the employee's apprehension of death or injury must be of such a nature that a reasonable person, under the circumstances confronting the employee, would conclude there's a real danger of death or injury and that there's insufficient time due to the urgency of the situation to eliminate that danger through resorting to regular channels. In addition, in such a circumstance, the employee, where possible, must have sought from the employer and have been unable to obtain from the employer a correction of the dangerous condition. That is balanced with OSHA's recognition that employees who refuse to comply with OSHA standards or with valid safety rules implemented by their employer are not deemed to be exercising any rights afforded by the Act, such that OSHA recognizes that disciplinary measures taken by employees in response to employee refusal to comply with appropriate safety regulations and rules is not ordinarily to be regarded as a discriminatory act prohibited by 11C. So again, OSHA is going to look at the reasonableness of the conduct of both the employer and the employee. And if, in fact, the employer has provided the employee with competent training and appropriate PPE, it should be difficult for the employee to make the case that he or she can refuse to work with an Ebola patient in that situation.
Okay, and we've received one additional question asking about employers who are paying their employees while they remain off work for 21 days. If employers are going to require employees to not work for that 21-day period, not because the employee's displaying any symptoms of Ebola, but just out of an abundance of caution, two concerns. One, there is the potential that an employee could claim that you are perceiving them as disabled, and by requiring them to stay at home when they're not displaying any symptoms of Ebola, that might be discriminatory. So in light of that, if you are still going to move forward with a policy that says you can't work for 21 days if you've traveled to West Africa and there's no symptoms being displayed by the employees of Ebola, then by paying the employees for that 21-day absence, you're mitigating the potential damages to the organization and also making it less likely that an employee will be disgruntled and feels a need to hire an attorney and file a claim against the employer. And also for morale purposes and PR purposes, paying the employees might help to maintain a positive work atmosphere.
Thanks, Katie. I think we've reached the end of our time. Thank you so much for joining us today. We will be sending out an evaluation, and we would ask that you please fill that out and give us some feedback. If you have any questions that we haven't gotten to, I know if you have come in since we were wrapping up here, please feel free to email any of us and or contact our marketing department, and we'd be very happy to help you out. Thanks so much.